According to their caliber, arteries are divided into 1. Large aorta, main branches of the aortic arch and iliac arteries, all of them provided of a big deal of elastic fibers in the tunica media. B. Medium-sized arteries, such as coronary, renal, mesenteric, femoral arteries, all provided with a thick, muscular tunica media, and small arteries, also named arterials, which can be observed through the skin and retina. Focusing on pathogenesis and anatomopathology, the acquired arterial diseases are divided into 1. Diseases affecting the structures and compliance of the wall, leading to aneurysms and dissections, with the main symptoms being localized pain, hemorrhages, and fistulas. 2. Thromboembolism, spotted by distal multiple necrosis, and 3. Punctual arterial occlusive diseases. Shifting now to focus on causes, aneurysms and dissections may occur due to A. Traumas, and B. Inherited, meaning genetics-based, connective tissues diseases involving the chemical composition of the elastic and collagenous fibers. Although genetically determined, the arterial diseases with likely evolution to becoming predominantly occlusive are A. Fibromuscular dysplasia, B. Cystic adventitial disease involving the popliteal artery and veins, and C. Thromboangiitis obliterans, Buerger's disease, which also involves veins and nerves, with an inflammatory component in heavy smokers. All the three main acquired artery diseases may be caused by the arterial wall inflammatory process. The diagnosis of a specific arthritis is based on 1. Sizes of the affected arteries, 2. Evidence of inflammatory biohumoral parameters of immune response, such as erythrocyte sedimentation rate, C-reactive protein, and different autoantibodies, etc. And 3. Histological tests from skin biopsies in small-sized vessels arthritis and surgical specimens. Last but not least, for the high prevalence, all three main acquired artery diseases are caused by arteriosclerotic changes, age-related stiffness of the wall, which is estimated by the high velocity of the brachial ankle pulse wave, and atherosclerotic changes from the multifaceted appearance of the cholesterol calcium plaque, whereof evaluation includes several parameters of the ultrasound Doppler test. In addition to asking about tobacco habits and establishing any clinical sign of arterial occlusive syndromes, the physical examination starts by estimating the blood pressure. If hypertensive, the patient is examined for secondary hypertension, renovascular, or hypersecretion of mineralosteroid hormones. The palpation of the neck vessels, pulses, and the auscultation of neck murmurs may lead to the carrying out of a color Doppler ultrasound scan and continuous waveform spectral Doppler ultrasound scan over the carotid, vertebral, and even ophthalmic arteries. The evaluation of the ankle-brachial index estimates the poor compliance of the overall arterial branching system through the pulse wave velocity and the distal blood flow reduction on one side to be properly investigated through color Doppler and continuous waveform spectral Doppler ultrasound scan. Arterials are visible in the retinoscopy. The ventricular repolarization of the electrocardiogram may suggest both major coronary arteries occlusive disease and diffuse distal coronary occlusive syndrome, subendocardial ischemia. The increased left ventricular mass index and the septal and lateral wall diastolic relaxing indexes may also suggest microangiopathy of the coronary arterioles and incipient and myocardial sclerosis. Biochemistry supports in identifying other risk factors, such as diabetes, through fasting glycemia and glycosylated hemoglobin, total and low-density lipoprotein-bound cholesterol, triglyceridemia, and lipoprotein a. Creatininemia is the most important parameter to evaluate the nephromicroangiosclerosis. The color Doppler ultrasound scan and continuous waveform spectral Doppler imaging are the leading tests in order to get figures from arterial wall anatomy and blood flow profiling in real time. Nowadays, they are so visible at the general practitioners and with no risk for the patient that they mandatorily precede any other imaging test. The semiological parameters that can be collected are summarized in the table. 2004, renovascular hypertension due to stenosis of the left renal artery. Angioplasty and stent were placed, plus hypertensive drugs given, converting enzyme inhibitor and amlodipine. Hypertension was brought under control. 2010, chest pain because of coronary artery disease. Angioplasty and 3 stents were placed into the affected coronary arteries, plus antagonists of the beta-adrenergic receptor atenolol, given at 100 mg per day. The chest pain disappeared. 2022, gripping pain in the right calf for 50 meters walk, which was remitting in 3 minutes' time following seated rest. The clinical diagnosis was claudication intermittens due to arterial occlusive disease. Atenolol was discontinued under the assumption that it was preventing the heart rate and the cardiac outflow per minute from increasing under physical stress. The walk range increased to such an extent that the longer range resulted in gripping pain in the left gluteal muscles. At the physical examination, no dystrophic lesions and discolorations of the skin and nails were observed in his feet. Arterial pulses were not palpable in the left submalleolar area, posterior tibial, and on the dorsum of the left foot, anterior tibial, in contralateral position related to the main symptoms of the arterial occlusive disease. The abnormal ankle-brachial index confirmed that the left side was worse than the right side, since the systolic pressure of the anterior tibial artery dropped to 190 mm mercury against over 140 expected. The brachial ankle pulse wave velocity was not that bad. Therefore, the atherosclerotic occlusive disease was worse than the poor compliance of the arterial branching system. On the right side, stenosis and increased blood velocity were observed in the external iliac artery, as well as in the common femoral artery, and the stenosis and calcification were visible all along the superficial femoral artery. The internal iliac artery was normal, since the peak systolic velocity of its terminal inferior gluteal artery was more than 39 centimeters per second. Conversely, on the left side, the origin of the internal iliac artery was stenotic, with high peak systolic velocity of 180 centimeters per second, a drop in the superior gluteal artery to 20 centimeters per second, and no diastolic flow at all. The 253 centimeters per second of peak systolic velocity gave evidence of stenosis, also in the left common iliac artery. Stenosis and calcification were present in the superficial femoral artery down to both the posterior and anterior tibial arteries through the popliteal artery. The left peroneal artery had no flow inside. The angio-computed tomography scan confirmed the overall pictures in all its details. The improvement in walking range, as it was achieved by terminating atenolol intake, encouraged the patient not to undergo angioplasty for the time being. But he agreed to add cilostazol as a vasodilator to his treatment. Unfortunately, cilostazol has also a platelet aggregation inhibiting effect that, in combination with acetyl salicylic acid, caused an intestinal hemorrhagic adverse reaction. Thus, the patient discontinued silastazole treatment. The general practitioner drew up a plan of rehabilitation to progressively increasing physical training and walking range. Most likely, such training was successful in expanding meshes of the collateral vessel branching, since the walking range increased to more than 1 kilometer on the plane, and in the meantime, the gripping pain in the left gluteus disappeared. 2 years later, the eco-doppler situation was unchanged. Never smoker, familial anamnesis for vascular disease negative. The patient, a bit overweight, was operated on the bilateral saphenous vein stripping because of varicose veins in his 20s. He had undergone treatment A. against mild hypercholesterolemia and hypertriglyceridemia with statins and ezetimibe. B. against mild hypertension with sultans. C. with 150 mg of acetylsalicylic acid as an inhibitor of platelet aggregation. By chance, an asymptomatic subrenal aneurysm of the abdominal aorta was spotted in computed tomography imaging of the abdomen performed for other reasons. The following tests were all normal: ankle-brachial index, electrocardiogram, and heart ultrasound scan. Even under physical stress, and morphology of arterials at the retinoscopy, ascending aorta, aortic arch, and the supradiaphragmatic descending aorta. The abdominal aneurysm was less than 4 centimeters in diameter, with some thrombosis in the anterior right wall, but no distal thromboembolism syndrome. No dissection was evident as well. Thus, no surgery was proposed for the time being, with only ultrasound scan follow-ups performed every 6 months in order to estimate the trend of the aneurysm diameter. 2 years later, early in the morning, the patient awoke, noticed a sudden pain to the left half of his face, and thereafter the loss of the proprioceptive sensory in the right half of his body, leg, shoulder, and hand. In 2 hours' time, he underwent synchronous teleconsultation. The thermal and pain sensory and motorial capacity were untouched. The function of the 3rd, 6th, and 8th cranial nerves were intact as well. The diagnostic hypothesis was alternating proprioceptive hemianesthesia. Through a magnetic resonance imaging test, the cause of the proprioceptive hemianesthesia was due to infarction of the left contralateral dorsal column medial lemniscus pathway. The left half-face temporary pain was supposedly due to ischemic lesion of the left 5th cranial nerve. The recovery of such anesthesia was slow and uncompleted. 1 year later, an identical but lighter loss of the proprioceptive sensory occurred on the left half of the body, and a small infarction was spotted on the right dorsal column medial lemniscus pathway at the pons level. The contrastrographic magnetic resonance imaging showed no arterial obstruction and or aneurysms of the Willis circle or the posterior cerebral arteries. However, the basilar artery was tortuous and pushed towards the right side by a big left vertebral artery, which was prevailing on a smaller right one, and the right anterior cerebral artery was missing. The pathogenetic hypothesis was that the patient was affected by arterial tortuosity. The basilar artery is so displaced from its central location that the pontine arteries, arising at 19 degrees, had been bent by such basilar artery pushing to sideways. In the ultrasound views of the neck, the flows and velocity of the carotid arteries and vertebral arteries were normal. In the submandibular view of the extracranial carotid arteries, close to the carotid siphon, no abnormal signals could be detected as well. Velocities and flow of the vertebral arteries were conformably different. 15 milliliters on the right against 50 milliliters per minute on the left, but the flow of the blood in the basilar artery was stable at around 200 milliliters per minute, even after both strokes. By putting together vein laxity, aorta aneurysm, and tortuosity of the basilar artery, the conclusion was that the patient may be affected by a congenital defect of the connective tissue of the vascular system, and a wide genetic investigation was proposed. Over the later 3 years, the patient, a waiter who is hypertensive and heavy smoker, had been reporting pain in his lumbar backbone spreading down to the right gluteus, thigh, and calf. The neurologist requested magnetic resonance imaging test. Hernias of the intervertebral discs L3-L4, L4-L5, and L5-S1 were spotted to imprint the dural sac at some extent. The neurologist offered anti-inflammatory drugs and swimming-based physiotherapy. Over the following 6 months, despite the treatment, the pain got worse, especially while walking, to such an extent that he had to stop working as a waiter. Upon an accurate physical examination, the pain was related to such a severe claudicacio intermittence of the right gluteus, thigh, and calf muscles that it was occurring upon a few meters walking and remitting soon upon resting seated. In an abdominal ultrasound examination, the general practitioner spotted an atherosclerotic aneurysm of the abdominal aorta, 5.2 centimeters diameter and 10 centimeters length, below the origin of the renal arteries. In the computer tomography, no dissection of the intima was evident. A circularly shaped thrombus was decreasing the transversal area of the lumen of the aorta. The saccular aneurysm was extending down to the origins of both the iliac arteries. In the right iliac artery, the thrombus completely occluded the lumen. The flow along the right common femoral artery was partly restored through inferior epigastric and spermatic arteries. The estimation of the ankle-brachial index was not feasible for the overall situation of the aorta and the iliac artery. Smoking was immediately and completely suspended. Hypertension was put under control through the calcium channel blocking agent nifedipine, 10 milligrams twice per day. Both cholesterol and low-density lipoprotein-bound cholesterol were abnormally high, 217 and 144 milligrams deciliter, and therefore the patient was offered statins. Thereafter, the patient successfully underwent aneurysmectomy and insertion of Dacron aortoiliac bypass graft. The sutures were fixed to the left common iliac artery and to the right common femoral artery. The claudicacio intermittence disappeared, and the patient recovered to return to his previous job. The lessons learned were the following. 1. Atherosclerosis risk factors evaluation and control are practices general practitioners can carry out on their own and at full extent. 2. The differential diagnosis of claudicacio intermittence and backbone pain is based on the anamnesis and not on imaging tests. 3. An accurate eco-doppler ultrasound scan and continuous waveform spectral Doppler provide detailed figures and must always precede other imaging tests. In some of the most distal lesions, femoral, popliteal, and tibial, the patient might even undergo interventional radiology without previously undergoing contrast media iodine computed tomography. 4. Beta-adrenergic blocking agents may disclose arterial occlusive disease in the inferior limbs. Thus, their suspension may provide outstanding improvements in walking range. 5. Training to progressively increase the walking range is essential to improve blood flows to ischemic limbs by expanding the mesh of the vascular branching. 6. The estimation of the maximum diameter, either anterior-posterior and lateral. In ultrasound axial view, including the external layer of adventitia, is mandatory to make a decision regarding treatment. Whenever no dissection and no distal thromboembolic events are evident below 5.5 centimeters of such diameters, semestral monitoring is advisable rather than undergoing surgery and or interventional procedures.